once again, and welcome to another episode of Main Street Mental Health. I'm Shannon Paul. I'm a licensed professional counselor, clinical social worker, and substance use professional in the state of Wisconsin. I've got a few years of experience, I want to increase mental health awareness across our state. As well as our region. Just happy Mental Health Awareness Month, the month of May, as well as Happy International Tea Day. So just an FYI, tea, great for antioxidants, great for increasing your metabolism, things like that. So consider that as a beverage of choice from time to time. Today's topic is going to be on trauma therapy. Often, I think in the past, trauma therapy was always looked at a little bit more challenging and maybe for a lot of people scary, to sum it up simply. Um, Trauma counseling, trauma therapy has really seen some advances over the last 10, 15, 20 years in terms of technique and success rates at resolving or mitigating issues related to trauma experiences. I'm going to talk a little bit about the history of different techniques that developed, as well as some of the ideas of what trauma is, and that's about it. Kind of try to keep this short and sweet. As this topic, though, we could have many, many, many episodes on this particular topic, but I just want to give you a general overview of that. If it's something you're considering for yourself, for a loved one, please take this information and utilize it. You might be able to find a provider in your area that is skilled at any one of these particular techniques or approaches. Bottom line is, though, finding a good counselor, which is one of my earlier episodes, is the most important thing. Relationship, relationship, relationship. All right, here we go. The one thing, how we usually end up seeing somebody in the counseling office is when they are experiencing something called PTSD, which stands for post-traumatic stress disorder. And most people have heard of that nowadays. There's also acute stress disorder, which is within 6 months of a particular event happening, typically. It also called for a lot of people and a lot of different things. There's another effort called CISD, or critical incident stress debriefing. Those critical incidences and traumas sometimes are the same type of thing. They're scary events. That's how I describe it to a lot of my clients. Any scary events in your life. Interesting enough, I really like the critical incident stress debriefing model, which is kind of fallen on disfavor over the last maybe 10 years or so. It is something I'm trained in, and I see some benefits, especially the initial 1 to 2 days after an event happens. There's some benefit, I think, from some approach similar to that. Even just talking about particular events that happen, sometimes that can be helpful just in and of itself. But they always phrased these types of experiences, which we'll call traumas, as a normal reaction for a normal person to an abnormal event or events that have occurred within that particular person's scope of life. Traumas can come in all shapes and sizes. It really is kind of experientially, whoever's experiencing it determines a lot of it. There's an old research I remember in my child protective services days. There's some research on children who've experienced either significant neglect and or abuse. And it found that about a third of the individuals that experienced some sort of traumatic event or events then developed PTSD at some point in time later on, especially if it was unmitigated, if there was no intervention early on. So that obviously that's those are the individuals that typically come through our offices, are the ones that are in that 1/3. But there's actually 2/3 of people that experience traumatic events from time to time that really don't have that significant PTSD response, which is fortunate. Thank goodness for that. But there's lots of variables that go into to that. I think studies and research on those people that are maybe somewhat immune to that response might be great to explore versus individuals that maybe haven't. I'm sure there's definitely more studies on that. So keep that in mind. You can have two people experience very similar events and have two different responses to it. So keep that in mind. Um, Trauma does affect us in a variety of ways, biologically, neurologically, emotionally. There are changes in our neurology, our neural pathways, how our body function and operates. They're legit. There's definitely been studies on neurotransmitters, biochemicals, hormonal things, and how they are affected by a particular trauma or a set of traumas in a particular person's life. And those can be measured actually. And there's a variety of different ways to do that. But so there are changes that can happen. Um, some of the symptomology that you see for PTSD, and most people are familiar, whether it's through movies or media or whatever. Flashbacks are a common occurrence, nightmares or terrible dreams, especially of an event or events. Stimulus responses, which I think are pretty common for people with PTSD. And stimulus responses are basically any of the senses that were involved in experiencing a trauma, those can be activated by something that's similar. So it could be a sound, it could be a voice, it could be a smell, it could be a sight of something, um, a taste of something, you name it. A location can all have kind of those stimulus responses, and those can be pretty difficult to deal with that from time to time. Um, as we transfer into like just talking about treatment, which is again developed quite a bit over the last 20 years, especially since I first started in the field. It's, at times when I first started in the field, I can empathize and I can listen, and we can definitely deal with anxiety and depression and some of the hypervigilance that comes along for the line. You can definitely mitigate some of those symptoms, but it often felt like it was like there was much more needed to help. So I'm pleased just as a provider that there are more techniques out there, and I've had the opportunity and blessings to be able to add some of those different techniques to my tool belt that when needed, they're useful, certainly. And really, I think the whole overall intention of trauma therapy or treatment is to kind of mitigate those neural pathways that we talked about earlier, and make a traumatic memory just a regular memory. So it's basically taking the intense traumatic memory and boiling it down, getting it down to where it's just a memory. It's just as if anything, that you have a memory about. So it doesn't have that escalation or that dysregulation that comes along often with traumatic responses. So that's kind of an intention or a goal. You want to reduce the symptomology and the reactivity to um, that particular trauma. I won't get into complex traumas and accumulation of traumas. There's certainly a lot of people we work with have multiple traumas, and often, sometimes with treatment, you can actually go through them one by one. Sometimes you can include them together and into one big what they call scene or experience, and process it that way too. So there are different ways to treat those things. I'll just touch base on some techniques for those of you that are not familiar with trauma therapies. There's a variety of trauma therapies that have been out there for many, many, many years. Um, Obviously, one of the early ones in late 80s, early 90s that was developed is called EMDR, and that's eye movement desensitization and reprocessing. And that's kind of the grandparent of some of the others that have come out since then. There's a cognitive behavioral therapy called TFCBT, or trauma focused cognitive behavioral therapy, that also was developed for children specifically, that is also out there, that takes a little bit different angle. I'll tell you this, in my experience in working with some individuals that have experienced some significant traumas, that we've had some just that there's some components in TFCBT, which there's something called a narrative. I have had individuals just uninvited or unprompted do narratives, and that in and of itself was a powerful, powerful experience for them, even when unprompted. So don't lose sight of TFCBT as well, which can be a very, very, very effective technique. Again, I think anytime you're bringing this information up and talking about it, each time you talk about it, it can have the possible reduction in symptomology because it becomes a little bit more of a everyday experience, everyday discussion, especially if you're talking with a trusted counselor, a trusted confidant of some kind, a trusted pastor, and it can be very, very helpful. Just discussing these things. That's why talk therapy is in existence, really, for when you think about it. So EMDR, it does utilize eye movements. It's basically bilateral stimulation, which is you're stimulating kind of both sides of the brain. You can do it through eye movements. You can do it through sound. You can do it through touch. So some people kind of do this side to side. Some people have headphones that click back and forth. You can actually have light boards that go side to side or lights that light, and you just kind of follow that with your eyes. Or people utilize their hands as well in EMDR. And EMDR is, again, amazingly enough, an accidental treatment that came about from the developer, Shapiro. And it was just on a walk and stumbled on a path in the woods. And she kind of went side to side and had kind of a image pop into her mind of a past issue. And she then developed the program from that, and it has helped countless people since then. So, and the next one I'm going to talk about is brain spotting. And brain spotting actually developed from, by accident, again, somebody doing EMDR, an EMDR practitioner in New York City, Dr. David Grand, and he saw a wobble in the eyes while doing EMDR, and he decided to stop. Normally it would be this side to side, and he stopped. And this particular individual focused on that spot and had a significant release of information just come pouring out of her. This was an Olympic hopeful skater. And she was there actually for sports psychology, trying to improve her performances and such. And the next day, she improved her performances. So after this experience, he further developed that particular technique. And brain spotting has developed since then. That's about 10 years younger than EMDRs, give or take, maybe 15 years younger than EMDR. And a very, very, very good model. I work with people that are very advanced in that particular technique, and it's amazing the work they can do. That's brain spotting. Brain spotting will utilize typically either a pen, sometimes they use fingers, but generally they'll use a pen, or sometimes they use pointers like this one, and they'll just kind of, they usually go across horizontal, and they find a spot, and that spot will be an activating spot, and there's resource spots as well, but I won't get into that too much in depth right now. But it's a very, in my experience, utilizing it, it's very good at bringing things to the forefront in a safe environment where you're involved with a particular provider. It's a safe environment, so the ability again to kind of talk about it and process it. The theory behind it is it actually brings those old traumatic kind of, they call it capsules or memories, those kind of filed storage files of trauma out, right out there, to kind of crack it open, then refile it and put it back into the regular memory file versus a traumatic memory file. So that's the theory behind it, and that seems to be what happens. It's very good at eliciting those capsules or those memories when I've utilized it in the past, and also from talking with other providers who, it's amazing. We've had some really cool experiences with that. So that's brain spotting. Another technique that developed from EMDR is called ART, which is accelerated resolution therapy. That also uses bilateral stimulation, and it can be, your hand, it can be a wand or whatnot. It can also be tactile. So it can be, there's things we call TheraTappers, which kind of give you a mild buzz, kind of like your phone buzz in both hands, back and forth, alternating. And that tactile bilateral stimulation can be almost as good as the visual. There's some auditory stuff too you can utilize, but typically that doesn't work quite as well. Brain spotting, I forgot to mention this. Brain spotting sometimes uses panned music that kind of goes side to side as well. So that can be really amazing and powerful as well to kind of hit those different senses. But ART really is kind of, to me, it's EMDR just expanded. It's just a really robust, and I'll say this, very specified, specific, detailed technique that it is quite amazing. It's really taking the EMDR and brain spotting, kind of adding layers of treatment, therapy, imagination, creativity on top of it. And as being a provider of that, it does do wonders sometimes. All these, I guess I mentioned four different techniques are fairly well out there now in terms of providers. ART is probably the youngest of them, and not as common maybe, but probably will be in a neighborhood near you at any moment. And it's one of my hopes actually too. Any one of these though can be very, very helpful. Um, the EMDR, typically with EMDR, you have a longer term relationship with a provider, and EMDR is utilized with it. Brain spotting is kind of designed for 4 to 12 sessions. ART is developed to be 1 to 4 sessions. So it's kind of getting, if you think about it, it's like 1 to 4 sessions. And honestly, when I do it, it's 2 to 3 sessions. I would say that's probably pretty normal for me to have a 2 to 3 sessions. There might be, a different thing that gets processed maybe a few months later or the like. But for a particular event or series of events, very effective at mitigating that distress that comes from it, making it a normal memory. That's the whole thing. I always highlight polyvagal supports, the neurology we talked about earlier, the vagus nerve, which kind of runs here down, is so important to our nervous system, and it does get damaged from trauma, neglect, uh, grief, separation, things like that. And anything you can do to kind of boost polyvagal, supports is going to be very helpful in concert with some of these techniques. You have a really, really good treatment plan, a really good chance of success in finding what you need. Um, the unfortunate thing is, most people that have experienced a trauma and maybe do have PTSD to some level don't usually seek services. So that's why during this month of May, I wanted to share this and just say, just if you know people that are struggling with these types of things, there are providers out there that can help. And sometimes you're talking 10, 15, 20, 30, 40 years ago, something has happened and it's still affecting people. What a wonderful thing to be able to kind of mitigate and reduce, and kind of open your life up again. So that's all I wanted to cover today on trauma therapies. Remember, we're just a percentage of perfect, and I wish you a happy Mental Health Awareness Month. Take care.